All right, we are going to get started in about 5 minutes. Go ahead, if you're just joining us, welcome, and go ahead and type into the chat box where you are tuning in from. Awesome. We have people from all across the world: Ecuador, Nebraska, Illinois. Excellent. All right. If you all can see me, go ahead and type in yes into the chat box. All right. Great. Good morning, everybody. Just a couple more minutes and we will get started. I'm so excited that you all are here. This session is going to be about an hour and 15 minutes, hour and a half, just to let you know. And I hope you guys can tune in until the end because I have some very special announcements as well. This is going to be a jam-packed session, guys. I'll see you in a couple minutes. All righty, everyone. Good morning here in Atlanta, Georgia. I am so excited that each and every one of you are here. We have a jam-packed classroom. We have a live stream on YouTube. This is going to be an epic session. Let's go ahead and get started. Well, today we are going to be covering top concepts from the NBME as it relates to cardiology. We have a ton of material to go through, but I just wanted to start with a little bit of an introduction. If you're new, welcome. My name is Rahul. I am a current second-year pediatric critical care fellow, and I have been absolutely passionate over the past 6 years of helping students just like you kick ass on the USMLE exam. I also want to welcome all of you who have been there from the beginning or who have recently joined the High Guru community. I am so excited to grow this project. And truly, I think that this is going to be such a great series of webinars as we kind of tackle all of the organ systems in the next few weeks. So I just wanted to start with the brief introduction. If you haven't heard of HiGuru, I know there's already so much out there when it comes to USMLE preparation, UWorld, first aid, pathoma. My goal with HiGuru is to really put in evidence-based strategies for USMLE preparation. All of my lectures, including today's, are focused on active recall. They are taught in an integrative manner. I want to relate concepts across organ systems, across domains. And most importantly, I am a big fan of giving students strategies on how to answer questions. I want students to have a systematic approach to test taking. So not only do you get good at the content, but you get good at the application of content. And my goal with HiGuru, honestly, is so that you at home can think like the test maker. So most importantly for HiGuru, the biggest thing, especially during this pandemic, we are a large community. I have been humbled to teach in medical schools all across the country. And honestly, we have now reached over 3,000 followers on Facebook. We're growing our Instagram. We're growing our YouTube channel. I want you to be part of this mission of spreading USMLE knowledge. We are now such an international community, a global community of lifelong learners in medicine, as well as future physicians. And guess what? It all starts with this one step. I know, dad joke, but we are really going to crush it in today's session and beyond. So just to give you a little bit of a background as to what inspired me to create this webinar, I think special thanks has to go to the Reddit Step 1 page, as there was a post not too long ago about the highest yield USMLE Step 1 concepts, and specifically the ones that show up recurrently on the NBME practice exams. What I am doing over the next series of webinars is organizing each of those concepts by systems so that we can cover all of the unique, highly tested material from the practice exams, as well as what may show up on your actual test day. Most importantly, guys, right now, please take out your notebook, make sure you get your caffeine, some water, because today's session is going to end with a very special announcement. I'm going to give you some details about my upcoming test-taking strategies and productivity masterclass. It's coming up in a few weeks, and I want you to be a part of it. It would really mean a lot to me, and this is such a unique webinar and a unique meeting that we are going to have, because it's going to give you the fundamentals on how you can make a damn good study schedule and think like the test maker. But before we go into that, I want to cover the top concepts in cardiology. Go ahead and pull up the chat box and type in yes if you are ready to crush this webinar. Are you guys ready? All right, wonderful. Excellent. Now, I know questions will come up throughout the webinar, and I promise you at the end of the webinar, I will answer live Q&A with you guys. But please, first, just pay attention, make sure you're taking notes, make sure that you are active and engaged, type in answers to the chat box, and then definitely save your questions until the end. All right, you guys ready? Rashi, Dilip, Funmi, awesome. We got so many people here today. Let's go ahead and go through the outline of what we're going to be talking about. All right, guys, so these are the top concepts that show up on all NBMEs related to cardiology. Number one, we're going to be talking about DiGeorge Syndrome. We are going to then go into a little bit of an integration of branchial pouch derivatives. Next, we are going to shift gears. We are going to talk about lipid lowering drugs. We're going to be talking about shock as well. Remember, shock on the USMLE, they're going to give questions related to arrows, and we're going to go through a test-taking strategy on how to approach those questions. We're going to talk a little bit about thermoregulation. What is our body's response to cold as well as heat? We're going to do a brief review on S3 and S4, talk about various types of murmurs, what makes them louder, what makes them softer. Guys, guess what these questions are going to be like? Well, they're going to give you those headphones and you're going to have to figure out what are the different murmurs that you hear. And towards the end of the session, we're going to go into the strategy on how you can crush those multimedia questions for your test day. Next, we're going to be talking about vasculitis. Specifically, what shows up, in my opinion, are the hemoptysis and hematuria syndromes. And then we're going to end with some post-MI complications. And I have some fun, unique pictures, as well as a timeline for us to go through as it relates to myocardial infarction. All right, guys, let's go ahead and start with our first concept, and that is going to be DiGeorge syndrome. I'm going to go ahead and put up a question here. A 2-month-old presents with seizures. He is lethargic and hypertonic. Patient is also found to have respiratory distress. This guy's sick. Exam is notable for a cleft palate, and a murmur is heard on clinical exam. What is the likely embryological mechanism seen in this patient? So, patient has seizures, a midline defect, a heart murmur. What do you all think is the answer here? Is it neural crest migration, a neural crest defect, third and fourth pharyngeal arch to develop, third and fourth pharyngeal pouch to develop? What do you all think? Awesome. We have a lot of good answers, and you're absolutely correct. This is a failure of third and fourth pouch to develop. Now, guys, USMLE questions related to DiGeorge syndrome, watch for the following. And anytime I'm stressing this stuff, you should write it down and make sure you're taking notes on this. Number one, always look in test questions for recurrent infections. Number two, make sure that you look for the heart defects, specifically tetralogy of Fallot, truncus arteriosus. Those are the heart defects related to DiGeorge syndrome. Number three, understand that these patients can get seizures. And what's the pathophysiologic mechanism? Hypocalcemia. And why is that? Because as we will see in the next couple slides, that the third and fourth pharyngeal pouch are going to be derivatives and give rise to the parathyroid glands, which are going to control calcium regulation. If you have low calcium, you can actually end up having seizures. And that's why this question is important, because it integrates multi-system involvement. Very important for us to know. So here is a test-taking tip for you all. And I'm going to intersperse these throughout the session. When I'm thinking about multi-system involvement, i.e., you see neuro-related, you see cardiac-related, do you see, just from the prior question, how many different organ systems were there? In exam questions, when you see multi-organ system involvement, you should think about syndromes or systemic conditions. Syndromes like DiGeorge syndrome, this is going to be seen in more of the pediatric population. And systemic conditions for your exam are going to be things such as infectious disease, rheumatologic, okay? These are going to be very important, high-yield things for you to paraphrase throughout the test question. And DiGeorge syndrome is a great example of a patient who has recurrent infections related to infectious disease stuff, as well as hypocalcemia. So now let's talk a little bit about branchial pouch derivatives. And I want to take a step back and talk about the pharyngeal system. Now, remember that we have pharyngeal clefts, we have pharyngeal pouches, and we have pharyngeal arches. Pharyngeal clefts are basically going to be ectodermally derived. And exam makers really want you to know that that is going to be ectodermally derived. When you're talking about pharyngeal pouches, that's what we're going to go into. That is going to be endodermally derived. And then pharyngeal arches, those are actually going to be mesodermal and neural crest derived. Just a little bit of a plug, in my free Golion style classroom course, which you can find on my website, I have a whole video covering the pharyngeal arch derivatives. I would highly recommend you to make a note and after this session, go through that video. So what we are going to do is we are going to be talking a little bit about the pharyngeal pouches. Now, pharyngeal pouches, what germ cell layer are they from? That is going to be endoderm. Very important for you to recognize. So here we are going to go through the first pouch. And the first pouch gives rise to the eustachian tube and the middle ear cavity. So one of the mnemonics that I'm going to use is ear. Ear is going to be related to the first pouch. The second pouch is going to be related to the palatine tonsils. Again, this is all in the head and neck region. Second pouch, 2 tonsils, we are going to be thinking about the palatine tonsils. Now, definitely put a star between the third and fourth pharyngeal pouch. The third and fourth pharyngeal pouch are the 2 pouches that are going to be abnormal in DiGeorge syndrome. The third pouch gives rise to the inferior parathyroids as well as the thymus. Remember, guys, as an immunology integration, the thymus is where the T cells are going to mature. And so remember that patients who have DiGeorge syndrome are going to have recurrent infections in your exam questions, specifically related to viral and fungal diseases. The inferior parathyroids are going to be derived from the third pouch. And remember that the reason why is because the third pouch actually migrates under the fourth pouch. And that's why you have the inferior parathyroids from the third pouch. And from the fourth pouch, you are going to have the superior parathyroids. The other thing for you to know is that parafollicular C cell, which secrete calcitonin, are going to be derived from the fourth pouch. Remember that that's going to be related to, yes, you got it, medullary carcinoma of the thyroid. That is a tumor derived from the fourth pharyngeal pouch, i.e. the parafollicular C cells of the thyroid. And what are exam questions that you're going to see with that? Well, you got it, MEN2 syndromes. Very high yield for you guys to know. Ladies and gentlemen, this is an integrative session. We're going to be going through various questions, and I want you to have the mindset of the test maker. How are they going to test these concepts? It's not just about rote memorization. It's about application and integration. Let's move on. Second high yield NBME concept is going to be the lipid lowering drugs. This is a hard one, but we're going to really focus on the mechanisms as well as the side effects. These are the things that they always test when it comes to lipid-lowering drugs. Let's start with this question. A 40-year-old female with history of Graves' disease is noted to have intermittent chest pain with activity. She has a history of an elevated LDL. She takes propylthiouracil for hyperthyroidism, and she has started on a medication to control her dyslipidemia. Which of the following best explains the mechanism of this medication? Why don't you go ahead and take a look at the answer choices and tell me in the chat, what do you think the answer is? Awesome. I encourage all of you to participate in the chat. I think this is such a unique webinar in the sense that we can have interaction. I'm fueled by your energy. You're fueled by mine. A lot of people are saying A. And what I want to do is give you a very important learning point. And that is, yes, this patient has started on a statin. You're absolutely correct. But statins inhibit HMG-CoA reductase, not HMG-CoA synthase. In fact, the answer here is going to be upregulation of the hepatocyte LDL receptor. This is exactly what statins do. Now, HMG-CoA synthase. What biochemical pathway is HMG-CoA synthase a part of? And that is going to be ketone body synthesis. Very high yield for you to know that the rate limiting enzyme for ketone body synthesis is going to be HMG-CoA synthase. Now, The upregulation of hepatocyte LDL receptor is going to take the LDL from the periphery and bring it in. So you have receptor-mediated endocytosis, and that's why LDL levels go down with statins. Another reason why I wanted to write this question is because I wanted you to recognize that statins, along with propylthiouracil, which is used for hyperthyroidism, both of those are going to be hepatotoxic. Very important for you to understand not only mechanisms of drugs, but toxicities. And that is why I think these kind of sessions, my resources are going to be very, very important, is because I want to stay up to date. Remember, November, December, there has been a push from the USMLE to not only do more ethics questions, but to also have more focus on mechanisms of actions of pharmacological agents. So guys, now what we're going to do is we are going to be going through the relevant drugs, and I just put in the need to know concepts, what they're going to test. So as we know, statins are HMG-CoA reductase inhibitors, and they are going to upregulate LDL receptors on hepatocytes, and that's exactly what we just talked about. That in turn decreases LDL, and the way that they can test statin toxicity is to tell you that hepatotoxicity, they're going to put AST and ALT in the test question being up, as well as if they want to test myopathy, they want to put elevated CK levels. Ezetimibe is going to be inhibiting cholesterol absorption. That specifically is going to decrease the Niemann-Pick-like channel in the enterocyte so that you are going to have decreased cholesterol absorption in the gut. Guys, the way that I'm going to draw this parallel is ezetimibe inhibits cholesterol absorption as it relates to dyslipidemia. Acarbose is going to inhibit sugar reuptake in the gut as it relates to diabetes. The parallels, the integration, I hope you guys are active and engaged. Just like statins, ezetimibe is going to also increase LFTs. The next drug that is very important for you to know is going to be bile acid sequestrants such as cholestyramine. Cholestyramine prevents the reabsorption of bile acids in the terminal ileum. Here's going to be another integration. Bile acids are going to be reabsorbed in the terminal ileum, as well as B12, very important. But cholestyramine specifically inhibits bile acid reuptake in the terminal ileum, and thus it is going to upregulate cholesterol synthesis. And when you upregulate cholesterol synthesis, you're going to then kind of decrease your cholesterol values because you have that reverse transport being inhibited. Because you are affecting the terminal ileum, these patients can have nausea and fat-soluble vitamin malabsorption. Remember, from a physiology standpoint, bile acids are really important in micelle formation, and thus you can have fat-soluble stools. Niacin is going to be the next medication. Niacin decreases fatty acid release, and remember that niacin is related to vitamin B3. Diarrhea, dementia, and dermatitis is the 3Ds when you're talking about a GI integration and niacin deficiency. And niacin nicely increases HDL. So the reason why I say this is niacin increases good cholesterol, nicely increases HDL. But what's important is that niacin has a bad side effect, and that is it can cause you to become hyperuricemic and exacerbate gout, but it can also cause you to have flushing and pruritus. And this is something that test makers are going to really look at times when they're talking about niacin. Specifically, the mechanism here is that niacin causes cutaneous vasodilation, and thus you can get some flushing as well as pruritus. Fibrates are going to be a very important medication. Fibrates are going to activate PPAR alpha, which is a gene transcription factor, and that's going to actually increase fat metabolism, and fibrates are going to reduce triacylglyceride levels. But just like statins, they can cause some myopathy. So statins in combination with fibrates can cause you to have elevations in your CK levels. One of the integrations that I wanted to make, and I just posted on social media about this, is the difference between PPAR alpha and PPAR gamma. This was something that easily confused me when I was going through my USMLE exam. And so when we think about PPAR alpha, remember it's going to upregulate lipoprotein lipase, and that is going to be at the level of the fat cell. And thus, you are going to increase triacylglyceride clearance and upregulate HDL synthesis with the activation of this nuclear transcription factor. Remember that fibrates are going to activate PPAR alpha. Now, where do we see PPAR gamma? We see PPAR gamma when we talk about diabetes drugs. And when we are talking about the farm correlations, that's going to be pioglitazone and rosiglitazone. And what do these medications do? Well, they increase insulin sensitivity as well as increase adiponectin levels. These peripheral insulin sensitizers are going to have a high yield side effect. And that side effect, frequently tested on exams, is that they cause a little bit of fluid retention. And so they can exacerbate congestive heart failure in patients who have underlying systolic dysfunction. So just to integrate a couple things we just talked about, which of the anti-hyperlipidemics can be hepatotoxic? Can you go ahead and type in the chat, which ones do you remember? Which anti-hyperlipidemics were hepatotoxic? Awesome. We have a lot of people who are going to be participating. I love it. I encourage all of you to participate. Awesome. So statins, ezetimibe, and even niacin up to a certain extent. But the ones that you got to know, statins and ezetimibe, those are going to be hepatotoxic. Now, just to review, what are the ways the test can ask this on the exam? Well, examiners want you to note that AST and ALT are markers for the liver, such that if they are elevated, you can be assured that, hey, maybe these medications, statins or ezetimibe, are going to be causing the patient a little bit of hepatotoxicity. All right, guys, which ones caused myopathy that we went through? Go ahead and type those in the chat. Which ones caused myopathies? Okay. Statins. Wonderful. Excellent. Great. I encourage you all to participate. Wonderful. And statins and fibrates. You're absolutely correct. This is a little bit of active recall, spaced repetition. And the way that test makers can attack this is they say increase in CK levels or CPK levels. These are going to be markers of muscle damage, as well as things like myoglobin. But I've really seen CK levels be tested a lot when it comes to not only rhabdo, but some other forms of myopathy. So when we're thinking about anti-hyperlipidemics, let's go through this very advanced question. And I don't want you guys to panic, but I'm going to walk you through this and see how there are some experimental questions that the USMLE can go for as well. So an experimental trial is studying the modulation of receptor-mediated endocytosis via clathrin-coated pits as it relates to lipid metabolism. Inhibition of receptor degradation via inactivation of the endolysosomal construct is noted to decrease LDL receptors. Wow, what an intense experiment. Let's break it down a little bit. When we talk about this experiment, they are looking at receptor-mediated endocytosis. They are talking a little bit about if you make sure that the LDL receptor stays up on the hepatocyte, you can actually decrease LDL levels. So what do you think this agent is? And this is a unique one. This is going to be a PCSK9 inhibitor. And these medications are elursumab and evolocumab, monoclonal antibodies. But this is a great example of how the USMLE could give you an experimental trial and ask you to actually relate concepts that you already know or content that you already know. This is a little bit of a schematic. Remember that when you're talking about the PCSK9, that is going to actually bind to LDL receptors, causing them to be degraded. So if you keep the LDL receptor up there by inhibiting PCSK9, if you keep the LDL receptors up on the surface, the LDL can be removed from the blood and the levels decrease. Persistent LDL receptor, that is what the PCSK9 inhibitors do. So let me give you a little bit of a test-taking strategy when it comes to experimental questions. Ladies and gentlemen, you know that these are just time sinks when it comes to your USMLE exam. I would encourage you to, on your first pass of the block, go through the experimental questions, put the answer, and I would encourage you to also mark those questions so that you can come back to it and double check your work. Let's go into a specific strategy on how to approach the experimental questions. If you get into the mind of the test maker, why do they put experimental questions? Well, in my opinion, test makers write experimental questions on the USMLE so that they can test you as the student. If you can organize elements of an experiment, if you yourself can interpret the data that they give you, and number three, relate the experiment to content you have studied. And so as a strategy, I would encourage you to, number one, don't panic when you see experimental questions. I would encourage you to also organize cohorts or groups or data sets. Basically, if the long paragraph is talking about a treatment group or a control group, make a mental model so that you can actually separate these. I would also encourage you to write out your givens if they're giving you some numbers so that you can organize the experiment well in your mind, and that prevents you from actually rereading. And then the third step is to have some element of relation to content you studied. PCSK9 inhibitors are going to be seen in, for example, first aid or other pharm resources. And so what's important is to take experimental data that they give you and relate it to content you've studied. These questions are tough, but if you follow a strategy, I believe that you can get closer and closer to the right answer. All right, guys, the next topic that we're going to be going through is shock. Ladies and gentlemen, this is a tough concept, but it comes up a lot. And I want you to recognize that USMLE questions love to go for arrows in various shock questions. Let's try to go through this one. I'm not going to ask you to actually answer this. I'm going to give you a strategy first, and then we're going to answer it together. Let's read together. A 50-year-old male presents with severe chest pain while mowing his lawn. His vital signs are pulse of 110, 20 breaths per minute, 105 over 70. He is cool and clammy. He is noted to have an elevated pulmonary capillary wedge pressure as well as a left atrial pressure of 20. What is the most likely pressure changes seen in the pulmonary vasculature? So we are going to be talking a little bit about, in the next slides, pulmonary capillary hydrostatic pressure, alveolar interstitial hydrostatic pressure, and alveolar interstitial oncotic pressure. One thing for you to just keep in mind before we go into the arrow strategy is this right here, how to interpret vital signs. I encourage you to make a note and watch my vital signs test-taking strategy video. What I want you to do is take quantitative data, i.e. these numbers, and turn it into qualitative assessments. What does that mean? Well, when I see 110, I say the patient's tachycardic, 20 breaths per minute, mildly tachypnic, and hypotensive. Anytime I see tachycardia and hypotension, I always think about shock. Also, you should take your qualitative assessment that you have and correlate it to the physical exam. This patient has cool and clammy extremities, and thus you're thinking that blood is not going to those areas. So let's take a little bit of a brief pause and go through a strategy on how to tackle arrow questions. Now, when we're talking about arrow questions, I want you to recognize that prediction before you go into the arrows themselves is key. Don't get lost in the sea of the arrows. Predict the variables prior to going into the answer choices. The second thing I say is start with the low-hanging fruit, i.e. the variable that you know, and then try to derive the other variables by branching out. So in summary, arrow questions for the USMLE. Prediction is key. Start with the low-hanging fruit and then branch out. So let's revisit our question. A lot of people in the chat said, man, this sounds like a cardiogenic shock. Yes, you're absolutely correct. So when you're thinking about cardiogenic shock, and in the test question, they say pulmonary capillary wedge pressure and left atrial pressure is 20. My low-hanging fruit that I'm going to go for here is the pulmonary capillary hydrostatic pressure. And I know that the pulmonary capillary hydrostatic pressure is going to be high because my wedge pressure is high, my left atrial pressure is high. And remember, the left ventricle is failing in this test question. So blood is backing up from the left ventricle into the left atrium into the pulmonary circuit. What is that backup doing? Well, pulmonary capillary hydrostatic pressure is elevated, and so is the alveolar interstitial hydrostatic pressure. If we look at this graphically, here is going to be the alveolus, here is going to be the pulmonary capillary. We note that the hydrostatic pressure of the pulmonary capillary is now causing fluid to come out of the pulmonary capillary and into the interstitial space. And if we put in some X's, this is going to represent the alveolar interstitial hydrostatic pressure. And because there's more fluid there, dang, there's going to be a higher alveolar interstitial hydrostatic pressure. And what is that going to do? That's going to dilute out all of the proteins in the interstitial space. And if it dilutes all the proteins in the interstitial space, that's why the answer is low. So what does this elevated alveolar interstitial hydrostatic pressure have to do with high yield concepts on the USMLE? Well, guess what? If you have an elevated interstitial hydrostatic pressure, i.e. more fluid within that interstitial space, that can actually do what? That can flood the alveolus. And that's how you can get pulmonary edema, which they love to test about, as well as on your physical exam, and they write this in test questions, crackles on exam. Anytime I see crackles on my physical exam, I think that there is some sort of fluid in the alveolus, or there's some element of fibrosis that is going on in the lungs. That's what crackles are going to help you hone in on your exam. Remember that the fluid that is in the lungs can be transudative or exudative. Remember, exudative is going to be related more to what? More to inflammation as well as infection. Whereas transudative, which is the type of fluid that we see that flood the pulmonary capillaries and the alveoli in cardiogenic shock, transudative fluid is going to be seen in pressure changes when you talk about changes in hydrostatic pressure as well as oncotic pressure. Ladies and gentlemen, this is what we just did. We went in, we talked about how to approach vital signs. We recognized the presentation of cardiogenic shock. We also talked a little bit about the mechanisms as to how we can, or the strategy as to how we can go through arrow questions. And then finally, we went through some integrations with pulmonary physiology as well as physical exam findings and ended it with GenPath. Ladies and gentlemen, this is the way to learn. We are going to be going through this webinar in an active recall and integrative way. All right, so when we're talking about shock for the USMLE, you want to understand what is the primary etiology that triggers the downstream response. In cardiogenic shock, for example, it is pump failure, i.e. low cardiac output. We're going to be talking about other types of shock in the next slides. When you're thinking about the parameters that the USMLE tests for shock, think about these. Cardiac output, which is representative of the blood coming out of the heart. Total peripheral resistance, as Pathoma even says, that is usually guided at the level of the precapillary arterial. Pulmonary capillary wedge pressure. Pulmonary capillary wedge pressure, very important. it is going to be a surrogate for left atrial pressure. Basically, the catheter is going to go right atrium, right ventricle, pulmonary artery, and it gets wedged in the pulmonary capillary circuit, and that becomes a surrogate for left atrial pressure. It's like me being here and knowing what's going on with you all the way where you're at. It is a surrogate for left atrial pressure, such that if left atrial pressure is high, pulmonary capillary wedge pressure is going to be high. And I want you to put a star here because SvO2 represents mixed venous oxygen saturation. And this is actually related to oxygen extraction. Remember that in times of shock, what happens is that you are going to have an increased metabolic demand. That increased metabolic demand is going to trigger your tissues to do what, guys? It is going to trigger your tissues to extract more oxygen. So if it extracts more oxygen, what comes back to your heart is low mixed venous oxygen saturation. So the take-home point for your USMLE is that if you have a low mixed venous oxygen saturation, think about your oxygen extraction being high. They are inverse to each other. Let's build this concept a little bit more. When I, in the ICU, put in an internal jugular catheter, I want to measure at times the mixed venous oxygen saturation. Remember, this is right near the heart. And what we note here is that the mixed venous oxygen saturation is usually measured by a catheter at the internal jugular or subclavian vein, and it is a surrogate for oxygen extraction, such that, especially in times of shock, if you have high O2 extraction in the peripheral circulation, i.e., you have increased metabolic demand, you are going to have a low mixed venous oxygen saturation within the SVC or internal jugular region. Let's go ahead and build on this a little bit more and talk about the various types of shock for the USMLE. So we just talked about cardiogenic shock, and the strategy is figure out what is causing each of these shocks. So I said in cardiogenic shock, your cardiac output is low. Well, if your cardiac output is low, you are going to have backup, and that's why your pulmonary capillary wedge pressure is going to be high. Well, remember that your organs want to maintain some element of perfusion. So what happens? Your systemic vascular resistance goes up in order to maintain tissue perfusion pressure as the pump is failing. And remember that at the peripheral tissues, because you are in cardiogenic shock and you have low delivery of oxygen, a concept we're going to get to soon, you are going to have a low mixed venous oxygen saturation. And just so that I know you have the concept down, if you have a low mixed venous oxygen saturation, what does that tell you about oxygen extraction? Go ahead and put that in the chat. Is oxygen extraction high or low if you are going to have a low SvO2? Excellent. You guys know the concept, and we're going to keep moving on. Beautiful. Wonderful. So let's talk a little bit about hypovolemic shock. In hypovolemic shock, USMLE test questions are going to talk about hemorrhage, such as in trauma. Remember, your long bone fractures or pelvic fractures can actually cause you to lose a lot of blood. And so in hypovolemic shock, your LV EDV, which is your left ventricular end diastolic volume, which also means preload, your preload is low. And because the preload is low, your cardiac output is going to be low. Again, in order to maintain perfusion pressure of your tissues, your vessels clamp down a little bit, and that's why your systemic vascular resistance is high. And because you don't have enough blood, for example, or you're dehydrated, your SvO2 is going to be low. Now, why did I put the next two types of shock in Navy? Because these are two examples on your USMLE of distributive shock. When we're thinking about distributive shock and specifically septic shock is due to intense amount of cytokines that are going to cause you to drop your systemic vascular resistance. What are the cytokines? Well, IL-1, IL-6, TNF alpha. Do you see how we're integrating all of the immunology as well as the pathophysiology here? Because your SVR is going to be low, you are actually going to have a void such that the heart is going to start pumping a lot. And test questions like to go for this, and that is that patients with septic shock, specifically those patients with warm shock, are going to have the tendency of developing high output cardiac failure. And because there is high output cardiac failure, there is increased amounts of transit from the arterial through the capillary and into the vein. So what that means is that the tissues don't have time to extract oxygen. And because the tissues don't have time to extract oxygen, you are going to have less oxygen extraction. And if you have less oxygen extraction, what does that mean for your SVO2 or your mixed venous that comes back to your heart? Your SVO2 is going to be high. So very important for you to know that septic shock, especially warm shock, you get high output cardiac failure and increased transit through the capillary system and less time for extraction. Anaphylactic shock is going to be a type 1 hypersensitivity. Always watch in your test questions for triggers. They say a bee sting or peanut allergy. They are going to put the patient in your test question with a lot of atopy, atopic features. And so in anaphylactic shock, due to the histamine release and the vasodilation that ensues, you are going to have a low SVR. You are going to have so much edema that there is inability for your capillary and your tissue space to kind of come together. That's how I like to think about it, and actually extract that oxygen. So your SVO2 may be high and cardiac output is also going to be high. But the one that they want you to know, this right here, that due to histamine mediated vasodilation, you are going to have a low SVR, and that on your USMLE is going to be manifested as what? You got it. Low blood pressure in your vital signs. I can't stress that enough. Dissociative shock is going to be the last type of shock. And in dissociative shock, oxygen cannot actually dissociate from the hemoglobin. So this is what you see in test questions related to carbon monoxide poisoning. And this is where test makers are going to put in the test question that they were in a fire or they were next to a heater. They'll say winter type season. And in this scenario, what happens is that you end up having a dissociative shock such that oxygen can't be utilized. If oxygen can't be utilized, what happens? Your cardiac output is going to go up. Your cardiac output is going to go up. And when you are going to be thinking about not utilizing oxygen, this is a typo right here. So please make a change for yourself. The oxygen, mixed venous oxygen saturation is going to be high. So dissociative shock, you can't utilize the oxygen. So if the tissues cannot extract the oxygen, well, then what's going to happen? You are going to have high mixed venous oxygen saturation that comes back to your SVC junction. All right. One last type of shock that we're going to go through, and this is an important triad for you to keep in mind. Let's go through this question. A 30-year-old male is hit in the chest with a baseball bat. He is tachycardic and has shallow respirations. On palpation of his abdomen, a prominent jugular vein is appreciated. Bedside echo shows a collapsed atria in diastole. What is the likely physical exam finding that may be causing these underlying symptoms? Go ahead in the chat and tell me, what do you think the diagnosis is here? I'll give you a little bit of time. Go for it. Awesome. We got some answers. Wonderful. So in this scenario, the patient has prominent jugular veins. And if they have a prominent jugular vein, what that usually means is that the heart is unable to fill. And the collapse of the atria in diastole is going to be a very important echocardiographic finding that the USMLE can go for because it integrates an important concept that the atria does not have a thick muscular layer, such that if this is the heart and there is going to be fluid surrounding the heart, well, as the heart is going to relax in diastole, the non-muscular structures, i.e. your atria, are going to end up collapsing because there's fluid surrounding the heart. So the physical exam finding that you can see in cardiac tamponade is pulsus paradoxus. Pulsus paradoxus is an exaggerated decrease of your blood pressure when the patient is inspiring. Cardiac tamponade is going to have an EKG finding of electrical alternans, and that is this alternating amplitude of the QRS complexes, especially on the EKG. Watch for this EKG that shows up on exams. So the triad of cardiac tamponade is going to be JVD, hypotension, and distant heart sounds. And in my opinion, guys, it's not enough to make a flashcard that just has this triad. You have to understand, and that's where my passion is, as to how the test maker is going to approach these concepts. They're going to put elevated central venous pressures, or they'll put the physical exam of a prominent jugular vein. For hypotension, look at the quantitative data, i.e. the blood pressure, and then the distal heart sounds. Maybe they say abnormal cardiac exam or cardiac auscultation shows faint heart sounds. Very high yield for you to know. And the reason why the patient ended up getting cardiac tamponade was because of chest trauma. So this is an important cardiorespiratory concept. What I'm going to do is from cardiology section of first aid and respiratory in first aid, I'm going to mix them together and we're going to talk a little bit about oxygen delivery. How do you get oxygen to the rest of your body? Well, that is going to be a function of a few things, and that is oxygen content as well as cardiac output. So what are the mediators that carry oxygen around in our body? Well, it's going to be hemoglobin, the saturations of hemoglobin, as well as the arterial dissolved oxygen. So if you think about it like a car, forgive my artwork, the hemoglobin is going to be the car itself. The saturations are going to be the tires of the car. And then the P little AO2 is going to be the actual road, i.e. the fluid nature that the car is going to be driving on. Well, in order for that car to deliver oxygen throughout the body, you are going to need a motor or a pump. And that pump is going to be the cardiac output. And remember that cardiac output is going to actually be dependent on heart rate as well as stroke volume. And stroke volume is how much the heart is pumping. That stroke volume is going to be a function of contractility, afterload, and preload. Stroke volume is going to be dependent on cap, SV cap, contractility, which is related to the amount of intracellular calcium that is coming out of the sarcoplasmic reticulum, afterload, which is basically a marker of total peripheral resistance, and preload, how much blood is coming back to the heart. If there is less amount of preload, your stroke volume suffers and your cardiac output suffers. That's what we saw in hypovolemic shock, just to integrate that again. When you're talking about preload, test makers also want you to know that preload is also known as left ventricular end diastolic volume. It is the amount of blood that is left in the left ventricle at the end of diastole. So when we're thinking about even not only step 1, but step 2 CK in clinical practice, we use this concept to treat shock. We give epinephrine to increase our cardiac output. We give just the right amount of fluid so that we're on our Frank-Starling curve to optimize our preload. We make sure that there's no arrhythmias and we control our heart rate. We make sure that the patients are not anemic. We intubate and mechanically ventilate these patients so that they have good oxygen saturations and PaO2s. Ladies and gentlemen, the reason why I'm so passionate right now, you've seen my passion over the next 50 minutes. It doesn't even feel like 50 minutes have gone by. Is because I want to inspire you in your journey of going through this whole exam and studying each and every day for multiple hours, going through a lot of test questions. I want to inspire you at home, look me straight in the eye right now, to be the best physician you can be. Because honestly, when it gets to the patient's bedside, that's where it counts. All of these concepts, when we apply it to the patient's bedside, that is exactly where it counts. And I want you to keep that inspiration while you're studying. I don't mean to be cheesy. I'm really, truly, genuinely passionate about making sure that you not only take these concepts and get a damn good score, but make sure that you can help someone in need by applying these concepts. Let's move on. And the next thing we're going to be talking about is thermoregulation. So thermoregulation has been on some of the NBME questions. And what we're going to do is we're going to take the extremes of temperature. We're going to talk about response to shivering, as well as response to cold, as well as response to very, very high temperatures. So obviously, when you're thinking about a patient who is submerged in an ice bath, for example, the mechanisms that are going to be at hand to actually warm that patient up are going to be, number one, shivering, which is going to be mediated by the posterior hypothalamus. Number two, you are going to be thinking about the thyroid hormone. And number three, the brown fat. So let's go into these three concepts. When you're thinking about shivering, guys, shivering is probably the most important response to very cold temperatures. In fact, what shivering does is the brain is going to actually trigger the alpha motor and gamma motor neurons that are in your muscles, and that's why you end up getting skeletal muscle contraction. Thyroid hormone also goes up, and it increases your basal metabolic rate by increasing sodium potassium ATPase. And finally, just to integrate some autonomics, brown fat is also going to come into play to give you thermogenesis. Let's talk about the other extreme, and that's going to be your heat stroke. So a football player presents in the summer after fainting. He is noted to have a high temperature, tachypnea, and very rigid muscles, and CPK is elevated. Patient is also noted to have increased creatinine. A test-taking strategy, this means that, muscles are damaged, and this means, the kidney is damaged. What is the likely mechanism? Well, this is going to be a heat stroke, and a heat stroke is due to abnormal hypothalamic thermoregulatory response. So the hypothalamus doesn't control the temperature well. Let's go into the mechanisms at hand. So when we're talking about how our body deals with heat, there are a couple mechanisms. Number one is vasodilation. During hot temperatures, remember, you're going to be very flushed. And the reason why is because you want to expose the blood to cooler ambient air. That's why we vasodilate. The second thing that our body does is that we sweat. And we know this because when we're talking about sweating, that is actually dissipating the heat. And so patients with heat exhaustion or even heat stroke especially will have absence of sweating in your test questions. The pathophysiology is very important when we talk about heat stroke. The high body temperature due to the dysregulation cause proteins to denature. Remember, high temperatures. And just to integrate some GenPath, cell membranes are going to get damaged and you are going to have multi-organ failure. And we saw that when it came to the muscles as well as the kidney. All right, guys, couple more concepts and then we are done. S3 and S4 is next. Let's go through this NBME style question. A 62-year-old man dies while playing tennis. At autopsy, examination shows cardiac valve defect and concentric left ventricular hypertrophy. Which of the following valve abnormalities is involved in a sudden death? What do you all think is the answer? Go ahead and put that in the chat. All right, I need more people answering. We have over 100 people watching this. Everybody should be putting an answer. Awesome. Yeah, so it's going to be aortic stenosis. And aortic stenosis is going to cause you to have this concentric hypertrophy. Why is that? Well, it's because aortic stenosis causes an increased amount of afterload on the left ventricle. And as you can see, the response to elevated amounts of afterload is going to be the hypertrophy. Very important for you to know that hypertrophy is going to be the gen path integration to elevated amounts of stress to tissues. All right. So what we're going to do is we're going to talk about the S3 and S4 heart sounds. During what phase of the cardiac cycle are you going to hear the S3 heart sound? Well, you're going to hear the S3 heart sound where? Early in diastole. And you are going to hear this right after the S2 sound. And on your kind of auscultation, it'll sound like this. Kentucky, Kentucky, S3 gallop. It represents the rapid filling of the left ventricle. And so what I want to tell you is that USMLE multimedia questions are going to definitely have the S3 very prominent at the apex because that's where the left ventricle apex is going to be. So USMLE vignettes related to S3, mitral regurgitation. In fact, the S3 gallop, the presence of an S3 gallop is one of the best markers of mitral regurgitation severity. Remember that if you have excess amounts of end diastolic volume, because you have mitral regurgitation, you are going to end up having a dilation of the left ventricular myocardium, and thus you can hear the S3. You also will see this in dilated cardiomyopathy. This can be idiopathic, but usually dilated cardiomyopathy, we think of things like congestive heart failure. So what the pathophysiology here is that S3 represents the atria filling into a very dilated left ventricle. So think about this left ventricle expanding. And if the atria early in diastole is filling into this very dilated left ventricle, you are going to hear the S3 heart sound. Let's correlate that with the S4. The S4 is also going to be heard in diastole, but it's a late diastolic sound. It's actually going to be heard at the part of the cardiac cycle related to atrial contraction or atrial systole. So USMLE vignettes related to S4 are going to be vignettes which kind of relate to reduced ventricular compliance. The ventricle is not filling, and usually that's because there is hypertrophy of the ventricle. So remember that question we talked about in aortic stenosis in which the patient had concentric hypertrophy? Well, in that scenario, you may hear an S4. So what are the different types of causes of left ventricular hypertrophy? Well, we talked about aortic stenosis, but think about patients who have elevated blood pressure for a long period of time. Hypertrophic obstructive cardiomyopathy, or even just regular hypertrophic cardiomyopathy, are going to be classic vignettes in which you have left ventricular hypertrophy. Infiltrative process, such as amyloidosis. Remember, apple green birefringence is going to be the stain. And typically you're going to see this in patients who are going to have either inflammation or old age. And then finally, things like coarctation of the aorta. Remember, coarctation of the aorta can be related to bicuspid aortic valve as well as Turner syndrome. And so anytime you have high afterload to the heart, such as in these scenarios, you're going to have left ventricular hypertrophy, and you can hear the late diastolic sound, which is S4. So here's a summary. S3 represents rapid filling of the ventricles. You see it in states in which your left ventricle is dilated, as well as if you have an elevated amount of preload. S4 is where you're going to have the atria contract into a very stiff ventricle, and that's going to be seen in patients with left ventricular hypertrophy. All right, murmurs. Let's start with the question. A 15-year-old has grade 2 out of 6 holosystolic murmur, heard best over the left fifth intercostal space adjacent to the sternum. It increases with inspiration. The murmur is most consistent with an abnormality of which of the following valves? Go ahead, take some time. What do you think is the answer here? All right, ladies and gentlemen, the answer is actually going to be D. And remember that when you're talking about this patient is going to have a murmur that is heard where? Near the tricuspid area. And it increases with inspiration. Remember, right-sided murmurs are going to increase with inspiration. And so you notice that this patient is going to have an abnormality of tricuspid area. And you see that murmurs for the USMLE are best going to be captured by going through this strategy. And that is understanding the location of the auscultation and characterizing whether you're thinking about systolic or diastolic heart sounds. Remember that location is important. Second right intercostal space. Second left intercostal space, right? Aortic, pulmonic. You got to know where they are telling you to auscultate and then categorize whether you're talking about a systolic murmur or a diastolic murmur. Here listed for you are the different types of systolic and diastolic murmurs. I know murmurs are going to not only be challenging because of you listening to them, but understanding maneuvers to increase and decrease the intensity of the murmurs is also going to be important. I would also encourage you to look at my videos on murmur auscultation so that you get this concept in your mind. In general, the ones that I've seen highest yield and most frequently tested are MVP and HOCOM being louder when there is less blood in the heart. When there is less blood in the heart, you are going to have an earlier onset of click for mitral valve prolapse, and you are going to have a louder sound with hypertrophic obstructive cardiomyopathy. What are the maneuvers that are going to cause you to have less blood in the heart? Well, things such as Valsalva, which increases your intrathoracic pressure, and thus you're going to decrease your preload, as well as standing. Regurgitant murmurs are going to be louder, such as aortic regurgitation, mitral regurgitation, when you have increased afterload, such as via hand grip. So these are the take-home summaries, but I encourage you to review the whole concept as well. All right, two more concepts, and that's going to be vasculitis as well as post-MI complications. Let's just take a deep breath here. Hang with me. I'm telling you, this stuff is very high yield, and you've already answered over 70 active recall questions throughout this session. So how I recognize vasculitides on the USMLE is I look at it and I say, first off, a vessel is made up of 3 layers. And I say, vessel is made up of the intima, the media, and the adventitia. In vasculitis, all of these or some of these layers are going to be inflamed. And remember, blood vessels are everywhere. So on the USMLE, patients present with nonspecific symptoms such as fever, fatigue, weight loss, myalgias, and then multi-system involvement. Why? Because inflammation of blood vessels. Blood vessels are everywhere. So let's go into this and talk about the first vasculitis, and that's going to be giant cell temporal arteritis. When we're thinking about giant cell temporal arteritis, watch for this vignette. An elderly female presents with muscle pain and difficulty chewing. She states that she had transient loss of vision during driving. Her inflammatory marker, ESR, is elevated. What is the next best step in management? So the next best step in management is going to be give corticosteroids. Why is that? Well, you're worried about giant cell temporal arteritis, and the severe complication is vision loss. So remember that giant cell temporal arteritis is characterized pathologically by granulomas that affect branches of the carotid, such as the ophthalmic artery. This vasculitis is also going to be associated with this MSK vignette. What is the MSK vignette? Let's go through it. A 70-year-old patient with joint pain. She has fever and weight loss, again, non-specific symptoms. Exam shows difficulty climbing stairs and combing hair. There is pain and stiffness in the shoulders and the hip, i.e. the central structures. ESR is elevated and CK is normal. Let's just pause right here. CK being normal, guys, this is an example in test question strategy of a pertinent negative. They want you to think about, hey, this is not muscle related, this is joint related. And this is the presentation of polymyalgia rheumatica, which is also associated with temporal giant cell arteritis. Watch for proximal muscle proximal joint, stiffness. Hemoptysis and hematuria is going to be a very important presentation for you to recognize on your USMLE. The three things that you should be thinking of when you hear hemoptysis and hematuria in your test questions are good pastures, microscopic polyangiitis, and granulomatosis with polyangiitis, also known as Wegener's. So how do you differentiate them in your test questions? Well, good pastures is going to have hemoptysis and hematuria related to a type 2 hypersensitivity and anti-GBM antibodies. Microscopic polyangiitis, this is a tough one, but watch for a trigger or infection, non-specific symptoms, hemoptysis and hematuria, and a P-ANCA positivity. Remember, P-ANCA represents what? Antibodies to myeloperoxidase. Contrast all of that to hemoptysis and hematuria, and then if they put in sinus involvement, you're going to be thinking of granulomatosis with polyangiitis, and that's C-ANCA positive. And C-ANCA positive is going to be related to antibodies to antiproteinase 3. Important for us to also understand is that microscopic polyangiitis and eosinophilic granulomatosis with polyangiitis, formerly known as Churg-Strauss, both of those pathologies are going to have P-ANCA. However, eosinophilic granulomatosis with polyangiitis has asthma, eosinophilia, and granulomas. So how do you recognize hemoptysis and hematuria? Well, watch for the USMLE questions. They're going to give you RBCs on the UA as well as a patient coughing blood-tinged sputum. The last concept of the day, don't look at the watch. Stay engaged. Make sure you have the chat box up and stay tuned. The last concept, let's push ourselves. A patient presents with substernal chest pain, which he noticed after a hike with his grandchildren. He said that the pain stopped after he rested on a bench. He is a smoker and exam is normal. So pain with activity, you're going to be thinking about angina. And stable angina is characterized by a poorly localized pressure-like pain that is relieved with rest or nitroglycerin and is brought on by activity. In terms of the pathophysiologic mechanism as to how we treat it, we want to vasodilate via increasing nitric oxide concentrations. So in stable angina, you actually see atherosclerosis that is going to hit not all, but a majority, around greater than 75. That plaque is going to occlude the lumen. The plaques can then rupture and usually have superimposed thrombi. And if they rupture and actually almost occlude the lumen of the coronary vessel, what's going to happen? Well, you can get unstable angina, or you can get some element of subendocardial infarction, what we know as an NSTEMI. And so both of these are going to be related to a partially occluded, but almost occluded vessel. And unstable angina on your exam has negative troponins, whereas NSTEMI is going to have positive troponins. If you end up having a plaque that includes now the whole lumen, think about a transmural infarction, and that is characteristic of a true ST segment elevation, MI, what we know as a heart attack. So important concepts here are knowing the amount of plaque formation, the difference between stable and unstable angina, as well as the differences between unstable angina and NSTEMI. Watch for your troponins when it comes to those two delineations. So what is the most common cause of death after myocardial ischemia caused by coronary artery disease? And that's going to be arrhythmia. Usually patients after a heart attack are going to die of arrhythmia, especially within the first 24 hours. A patient presents dead to the emergency department. Autopsy shows what? Complete occlusion of the LAD, which represents a myocardial infarction. The likely cause of death? Ventricular fibrillation. Ventricular fibrillation is the most common pre-hospital cause of death in patients with myocardial infarction. And the most common in-hospital death is going to be LV failure. Now, you don't need to know the most common like that, like they're going to ask you that. They will give you other clues. And specifically related to LV failure or cardiogenic shock, remember that especially if you're going to have an aneurysmal dilation of the heart, it's going to take some time after a myocardial infarction. So remember that structural heart changes are going to take some time after a myocardial infarction. Typically look for the timeline of about 3 to 7 days. So think about things like ventricular rupture, mural thrombus, tamponade, papillary muscle ischemia causing acute onset of mitral regurgitation. Those test questions, it's going to be around the 3 to 7 day mark because it takes time. Arrhythmia is going to be much earlier. A patient's heart is studied on autopsy after he suffered a myocardial infarction. He presented to the hospital within 4 hours of the acute attack. What would light microscopy show immediately after his myocardial infarction? Well, you're going to be thinking about really no visible changes because the first changes occur at the 4 to 12 hour range, and that's where we see the wavy fibers and the elongated myocytes. And this just represents myocyte damage. Just to integrate some GenPath, afterwards cell death can ensue. And that's where you see pycnosis, karyorrhexis, and karyolysis. And remember that cell membrane damage and mitochondrial damage is a sign of irreversible cellular injury. So what we're going to think about is that inflammation is going to be first started with the neutrophils and coagulative necrosis. At 1 week, the macrophages come in. So 1 day, neutrophils. Around 1 week, macrophages. And you start getting granulation tissue. Now, during this time, remember to watch out for structural complications, such as free wall rupture, septum rupture, papillary muscle rupture. In papillary muscle rupture, the test questions are going to be related to a new onset murmur. At a month's time, the patient can end up having scar formation. And just to integrate some pharmacology, remember 1B antiarrhythmics, which are sodium channel blockers, 1B, such as lidocaine and mexiletine. Lidocaine and mexiletine are your two class 1B sodium channel blockers that are the best after MI, best after some sort of heart damage. Watch for that pharm integration. We are going to conclude with a timeline of myocardial infarction. Remember 0 to 4, minimal change. 4 to 12 hours, early coagulation necrosis and wavy fibers. You're going to then have at the 12 to 24 hours, contraction bands. Keep that in mind. And then you're going to have neutrophil migration followed by macrophage migration, 1 day, 1 week, and then granulation tissue that is going to be composed of fibroblasts, capillaries, and myofibroblasts. And long-term, you can have collagen deposition and scar formation. Understand that timeline is important when you're answering questions for myocardial infarction. Here is the last slide of the day. This is a past slide that shows those contraction bands. Look at the pink structures in this picture. And the pathophysiology of contraction bands are twofold. Number one, because you damage the myocyte, calcium is released, so it causes you to tense up. But if you even think about a calcium independent mechanism, you have persistent activation due to actin and myosin being kind of stuck on each other because there's low ATP. Why is there low ATP? Because you cut off the blood supply in your myocardial infarction. Ladies and gentlemen, that was the review. Thank you guys for attending. I encourage you just to spend 2 more minutes with me. Just as a summary, today we went through top concepts related to cardiology. I encourage you to also attend the other webinars. But most importantly, I want you to have the opportunity today to sign up for my masterclass that is coming up, going through test taking strategies for the USMLE. Now, as you see, I'm energetic. I put in the work, and I want to make sure that your score is optimal and you can apply the content. And that's why I made this course. You're going to be receiving a lot of value, guys. And I want to make sure that if you sign up, you can not only learn the strategies, but you can also be very productive on a day-to-day basis. Make a damn good schedule. This is so unique. It's a great opportunity for you to elevate your scores. And if you would like to go through other resources, feel free to just check out my website. I'm going to go ahead and type in my website and where you can actually sign up for the course. Look at the chat, higuru.com/TLTM. And why did I put TLTM, guys? Because it's thinking like the test maker. And that's exactly what I want you to do. Thank you guys so much for your attention today. And I'd be happy to answer any questions that you may have. I'll stick around towards the end until I go through all your questions. All right, thanks, guys. Questions?